My name is Curtis Santos. I am the Executive Director and co-founder of Boston LesBiGay Urban Foundation, and I'm happy to be here with you all this afternoon. We are here to discuss the monkeypox and what is the virus doing within our communities. I'm here to also share a platform with a lot of great folks and individuals to talk about the monkeypox, but beyond that, I want to actually shed light on our moderator. Her name is Sasha. Sasha, she comes with a plethora of background within the environmental justice and understanding communities and impacts within colors and marginalized communities. So Sasha, I just want to welcome you to the platform.
Thank you so much, Curtis, for welcoming me here and for the opportunity to meet all of these great panelists, which I'll introduce. So today we have 4 panelists joining us, and I'll list them out, including their pronouns, and I'll mention that my pronouns are she and they. And if you are comfortable sharing your pronouns, you can feel free to edit that next to your name via Zoom. So our panelists include Dr. Bisola Ajikutu, who's Executive Director of Boston Public Health Commission and uses she and her pronouns. We have Quincy J. Roberts, who's Executive Director of the Mayor's LGBTQ+ Advancement Office, using he and him pronouns. We have Kevin Cranston, Massachusetts Department of Public Health Assistant Commissioner and Director and Bureau of Infectious Diseases and Lab Sciences, also using he and him pronouns. Sorry, that was a little bit of a mouthful, but important.
You got it right.
And then lastly, but also importantly, Dr. Esteban Garcia, who's Chief Medical Officer of the Massachusetts Department of Public Health, also using he and him pronouns. Welcome, everyone, and thank you so much for being here. And so we are ready to start and on time. I'll ask Dr. Bisola Ajikutu to start us off. And I just want to mention 2 quick caveats. One is that this is designed and meant to be an accessible space. So if there are any issues that you wanted to bring up to the organizers, feel free to do that via the chat, or you can interrupt the meeting to share any of that or share that with me on the side. We also do suggest the chat function, especially for questions. There will be a question and answers portion later on in the meeting. And lastly, Curtis mentioned that I'm a lawyer. I just want to mention that I'm here in my personal time and capacity, not representing my employer's opinions or interests. So welcome everyone, and Dr. Bisola, take us off.
Great. Thank you so much, Sasha. Good afternoon, everyone. On behalf of the Boston Public Health Commission, I'd like to welcome you to this town hall and thank you so much for attending. I want to specifically thank our partners in this process and in this work, the Boston LesBiGay Urban Foundation, founder and executive director Curtis Santos, who I've worked with many times in the past, and it's doing great work across Boston City, work on behalf of our very diverse populations. The Black Boston Health Coalition and Senator Diane Wilkerson, who's also been very supportive of this effort, and the Mayor's Office of LGBTQ+ Advancement and Director Quincy Roberts. These groups, this community collaboration that we built really has dedicated a lot of time and commitment to community engagement, education, awareness regarding monkeypox in Boston. And I also want to thank our state partners who've, I've bothered many a morning. I know Kevin knows I've emailed and texted him many times to get his opinion on things and to build our collaboration. And Kevin's someone who I've worked with for decades, and also Dr. Esteban Garcia, who I've just gotten to know recently, but who's also been a great partner in this work. I think I just want to start by saying that since the first case of monkeypox to be diagnosed in the US was identified here in Boston back in May, the Commission and the City of Boston have worked in collaboration with the community partners who I've mentioned to lead outreach and engagement amongst Boston residents. Our overarching goal has really been to educate and to support access to services, particularly within communities of color, and importantly, to prevent stigma and discrimination against the LGBTQ+ community, specifically stigma directed towards gay, bisexual, and other men who have sex with men who've been disproportionately impacted. Our approach has intentionally been inclusive, it's intentionally been sex positive, and it's also incorporated harm reduction strategies as an important way to address this outbreak. We've also been very focused on vaccine equity issues. We all know the work that we all did, those of us on this call, as well as probably some of us in the audience, looking at vaccine equity in regards to COVID-19. Certainly, we are very much so in tune with ensuring vaccine access and promoting uptake throughout Boston. So hopefully, we can talk more about that and strategies and sort of think through how better to do that in regards to monkeypox. So since May, very specifically, I want to tell you that we have developed multicultural health education materials. So if you look on our website, boston.gov/monkeypox, and we can put that in the chat. Most of the clinical information that you hear this afternoon is available in 10 languages. I'm very proud of the fact that our Infectious Disease Bureau has been able to post that in so many languages. There are infographics and fact sheets that are available. Please download those, post those on your social media. This is how we address lack of awareness. This is how we overcome stigma. We put the information out there. And secondly, we've been engaging community members and organizations, clubs, bar owners, all sorts of folks to raise awareness in town halls like this. If we should do more of these, how we should do them. That's one of the reasons why we're here, to talk about this with you and to get a sense of which directions we should go in next. I also want to say that we are posting ads on dating apps, which is something that we think is incredibly important. You can take a look at those. Eventually this will be posted soon. Okay, so we'll put a pin in it, but it'll be out there soon. We will be on Grindr, Growler, Hornet, Adam for Adam, Scruff, and Jacked. And Jacked, I'm just learning, has a member base that's more than 70% African American. So here in the US, so I want to make that point that we are really out there meeting people where they're at. So again, thanks to our Infectious Disease Bureau, our comms department, all this work will continue just as long as it needs to continue. And I think that it's just really important for us to care about this, irrespective of who we are and who is currently most impacted. So the Massachusetts State Department of Public Health, Kevin and Dr. Garcia, has asked to provide the clinical and vaccination overview for this session, as well as to respond to your questions in that regard. I'm really looking forward to their presentation and hearing their responses to questions so that we can continue our work. So maybe should I just turn it directly over to them, or Sasha, do you want me to give it back to you? Whichever way you want me to go.
So much, and look at you, we are right on time. Yeah, right.
You told me to stay within time.
I'll be holding y'all accountable, so this is great. But yes, please go ahead, Dr. Esteban Garcia and Kevin Cranston, and keep the conversation going. Thank you so much.
And give me one moment to just get this on slides from the beginning. And Dr. Garcia, you're going to take it away, right?
Great. Thank you. Yep. So Kevin, next slide. So thanks everybody for joining us. I really appreciate the opportunity for us to discuss a little bit about what monkeypox is and spend some time understanding what the needs are in the community as well. So I thought maybe we just level out a little bit on what monkeypox is. And so what we know is that this is caused by, it's predominantly an illness caused by a rare virus. The distinguishing feature of monkeypox for the most part are these pox or lesions. And interestingly enough, for the illness that we are, the current episode that we're seeing of monkeypox that started back in May, certainly has a predominance of lesions that are in the genital area and in the anus and around the anus. You can have lesions in other areas as well, but I think that's pretty distinguishing from what we're understanding. And these lesions can be quite painful and debilitating even with the pain that does happen, or itchy as well. And then some of the other symptoms, like many viral illnesses, you can have other symptoms that are general symptoms, and those are things like fever, chills, swollen lymph nodes, extreme tiredness or exhaustion, muscle aches, backache, headache, and some respiratory symptoms as well. Next slide. So I think it's also important not only to understand what monkeypox is, but it's important for all of us to understand how it's spread. And what we know about the current episode or occurrence of monkeypox is that it is spread through close personal contact. That contact can often, and really is skin-to-skin contact, and can be either sexual contact, can be contact with open sores that somebody may have, these open lesions. It's that liquid or the scab within the lesions that is most contagious. And you have to also consider other types of contact, which include things like kissing, massage, or cuddling. Those are all types of or ways to spread monkeypox. Anyone can get monkeypox. It's not limited to the gay and bisexual community or men who have sex with other men, but certainly that is our groups are being disproportionately affected. And I think that's important to understand. Monkeypox can also sometimes be spread through other ways, and that includes really thinking about personal items that folks have. So it's bed linens, bed sheets, towels, sharing of those things really makes it contagious as well. Also, utensils, cups, spoons, forks, things like that. Or we also think that it can be spread that way as well. Now, I will say that the respiratory droplet spread of monkeypox is not similar to COVID, and I think a lot of people understand kind of the COVID spread and how quickly that could happen. We really think this is prolonged contact and prolonged face-to-face contact without a mask, and so that again, level setting how this is spread is important, and it's unlikely. And I think these are kind of safe spaces, so it's unlikely to be spread in supermarkets or grocery stores, right? It's unlikely to be spread even in crowds where there isn't a lot of skin-to-skin contact. So if people are fully clothed, again, very unlikely to be spread there, or a brief handshake. Next slide. So again, thinking about how we prevent monkeypox, I think is why we're here and what the conversation we want to have. And it's really important to understand that it can be prevented. And primarily, if you have lesions or someone else has lesions that is consistent with monkeypox, it's important to keep those lesions covered and to prevent touching someone else's lesions. That's super important, and to prevent skin-to-skin contact with those lesions. It's also important to think about from a sexual perspective to avoid sex in those situations, whether you have those lesions or others have those lesions. That's important to understand as well. We also say don't share, don't share those cups and utensils and things with someone who has monkeypox. And the same goes for the bedding and the bed clothing and towels and linens. It's really important not to be touching those and sharing those in any way. And then, what I say, I'm a pediatrician, and so what I say all the time is washing hands. It really keeps us going every day and all through the winter with our kids. And it's super important to wash your hands in these situations as often as possible. And it's really soap and water is actually quite appropriate here, though you can use hand sanitizer as well. Next slide. So DPH really feels like the way we're going to prevent monkeypox is for folks to learn the facts, to understand that anyone can get monkeypox, that it's spread through this close personal skin-to-skin contact and sexual contact, that it's important to get checked if you think you have lesions that are unexplained, or new lesions, certainly in areas that you're concerned about in the genitalia or around the anus. I think it's also really important to talk with your healthcare providers and get tested. Testing is more available now than it was initially, and we're excited about that, to be able to offer that across the United States. And then also thinking about treatments, and Kevin will go into talking about our treatments and treatment options that are available, and also thinking about vaccines and how do we then prevent monkeypox by getting vaccinated. And we've certainly, while in limited supply, we want to make sure the right people are getting vaccinated to protect themselves. There were a couple of questions that I just wanted to touch on that came up, and one of those is whether or not you can get infected with monkeypox once you've had monkeypox and recovered. Now, remember, the recovery period can take up to a month. You need those lesions to be completely crusted over and the scab to fall off and new skin to form, and that can take up to a month. And so can you get monkeypox again? Well, we believe that the immunity from the monkeypox virus is actually quite robust, even better than our vaccines that we currently have. And so you are protected initially, certainly. I'm not sure how long that is, but it's pretty good immunity. And we're not at this point recommending a vaccine if you've recovered from monkeypox, at least not in the near term. And then the other question that comes up, I think, is a fair question, is thinking about whether or not, with a vaccine, can you get monkeypox, once you've been vaccinated? And so that we want to make sure we don't have any vaccine that's 100% efficacious or able to protect us from whatever it's a vaccine for. So yes, we have seen some breakthrough infections with the vaccine. And so it's important to understand that we also recommend that everyone keep a watchful eye out, even if you've been vaccinated, and try to keep yourself out of situations that could put you at risk. So I think that's also super important. And we're happy to answer other questions that we have, but I just wanted to touch on those two. I thought they were important for folks to know about. And I will kick it over to Kevin for the next couple of slides.
Thank you, Dr. Garcia, and thank you to the sponsors and to BPHC for inviting us. I haven't lived my whole life in Boston, but I've spent the last 42 years, my entire adult life in Boston. I'm a white middle-class cisgendered, openly gay man. It's important to mark ourselves in these conversations, and few to mark me for anything I say. While there are 2 vaccines against that are being used against monkeypox. One of them is not going to be subject to this conversation. It's one that's specifically designed as emergency preparedness against the possibility of smallpox being weaponized. Luckily, it is very difficult that one is very difficult to administer and has a lot of risk associated with it. Luckily, we have another vaccine known as Jynneos, G-Y-N-N-E-O-S, which is a vaccine that is also developed against the whole family of viruses that monkeypox belongs to, the orthopox virus family. These are located in the Federal Strategic National Stockpile, and these were previously produced and stored, again, for emergency use, particularly in the event of a bioterrorism attack. The federal supply is very strictly allocated and uses a formula based on the number of monkeypox cases by state, but also the number of eligible individuals, people at risk by state. And so the allocation we've been receiving has been coming to us in a multiplicity of phases, and we're just about to order our phase 4 allocation. But it is very strictly limited until a larger number of vaccines, which we do expect to be coming during the fall, allows us to, I think, be a little more flexible in how we are allocating the vaccines at a local level. On August 9th, CDC, the Centers for Disease Control and Prevention, and the Food and Drug Administration released what was called an emergency use authorization for this vaccine. This is similar to the way some COVID vaccines were initially rolled out, and allows us not only to use the Jynneos vaccine, but has advanced an alternative dose vaccination regimen for people over the age of 18. And we also allows for the use of Jynneos vaccine for certain individuals under 18 under a different regimen. The original way it was approved was a single dose vial of 0.5 milliliter. It's still a very small quantity of vaccine that is administered, and originally was administered subcutaneously, or a direct injection under the skin. And then the alternative regimen that was approved later in August allows for again, 2 doses. The original vaccine administration was also 2 doses, but for a smaller quantity, only 0.1 milliliter of the vaccine, to be injected directly into the skin, what's called intradermally, between the layers of the skin, where there are certain immune cells that can pick up on the vaccine, and evidence shows that it gets the same immune response that the full 0.5 milliliter dose injected under the skin would produce. The advantage of this is getting the same immune response with a smaller dose, and it has increased the number of available doses 5-fold. So it allows us to continue to vaccinate people for getting both their first as well as their second dose. So this has been a real boon to our vaccination effort. We in Massachusetts have chosen 14 vaccination providers who have demonstrated over the years their ability to reach gay and bisexual men, other MSM, men who have sex with men, and in particular men of color. All of these providers have great experience delivering vaccinations. They've proven it in the COVID response, and proven it in HIV and sexually transmitted infection work that they have done with the gay and bisexual male community and other men who have sex with men. Because of the limited supply, we required that these administrations be by appointment only. The healthcare providers themselves make the appointments. They perform a risk assessment, because there are some rules under which CDC has allocated the vaccine about who's eligible to receive the vaccine, and also determine whether a person may have been recently exposed to monkeypox, which is also a prioritization for people getting what's called post-exposure prophylaxis, or administering a vaccine after you've been exposed to prevent the emergence of the infection. All of the 14 sites are posted on our website, the mass.gov/monkeypox website. And we have mobile providers as well that can travel statewide. And we're working with community groups and venues that are serving gay and bisexual men and other MSM, particularly men of color, to host clinics with our mobile providers so we can bring the vaccine directly to men at risk. Once a provider confirms that an individual is eligible and that eligibility is recent exposure to a person with monkeypox, having had sex in the last 14 days with a person who you find out now has monkeypox, or a person who has had multiple sexual partners in the last 14 days, that allows the patient to make their appointment and to present for the vaccination, both the first dose, and at that point, a second dose appointment 28 days later will be made. These are the 14 providers currently administering in fixed sites, and you'll notice the first 5 are located in the city of Boston. Fenway Health and the Massachusetts General Hospital Sexual Health Clinic are high volume providers, particularly skilled in serving the gay and bisexual male community and other MSM. Boston Medical Center, East Boston Neighborhood Health Center, and Codman Square Health Center also have that capacity, and particular in reach into the BIPOC community. And then you see there throughout the state, there are other providers among these 14. As I mentioned earlier, these are the eligibility requirements, so I won't review this again for you. I jumped the gun on my slides. And many of the cases are within networks of self-identified gay and bisexual men, other men who have sex with men, transgender individuals who have sex with men. But people of any sexual orientation or gender identity can become infected with and spread monkeypox, particularly if they've been exposed to someone with monkeypox. So these are all the eligibility criteria for getting a Jynneos vaccine. I refer you to our Twitter feed, our LinkedIn materials, and particularly to the mass.gov/monkeypox page for more information about monkeypox, about vaccination, and about treatment. And I'll turn it back to you, Sasha. I will stop sharing and open up to the next presenter.
Thank you so much, Kevin, and Dr. Esteban Garcia. Thank you so much. Okay, so I'm going to turn over to Quincy Roberts, which reminder to everyone, since it's been a few minutes, he's a director of the Mayor's Office of LGBTQ+ Advancement. So take it away, Kevin. Oh, sorry, Quincy.
Thank you. It's okay. I've been called worse. How's everybody doing? Thank you so much for having us. Just want to give quick shout outs before I go into my spiel. Of course, Curtis and Keisha, Boston LesBiGay Urban Foundation, Black Boston COVID Coalition, Senator Diane Wilkerson, Adriana Bolin and Fenway Health, Gary Daffin and Mac, and then we have Todd with X Clinic and Codman Square Health. Those are the individuals that I've been working closely with when it comes to monkeypox. I got appointed June 1st, and July 1st, monkeypox hit. I took a vacation, came back. I heard about this thing that was similar to HIV. That's how it was given to me via text. It's like, hey, this new HIV thing is happening. It's directly impacting gay men. That's what my text read. So got back from Jamaica and just got on the phone and started to find out, like, this is nothing like HIV or AIDS, nowhere near it. It's skin to skin. Everything that Kevin and Dr. Garcia just went over, those were myths. So what I decided to do was on July 29th was to stop the hearsay. So I got with myself and Fenway Health, Adriana, and some other community members, and we hosted a private town hall where we really wanted to hone in on club promoters, because that's what was the information that was being given to us, that this was being impacted by or for performers and club promoters. So we have 51 club promoters and performers that identified all throughout the LGBT community and BIPOC community. The only thing that I think that we could have did a better job of was opening to the community. And we do want to apologize on the public forum that we had this impromptu town hall because that's what we thought was the right thing to do, which kind of leads us to the outreach strategy that myself and the people I just named, we decided to do on our own. Nobody told us to do this, forced us to do this. This is just something that we wanted to do for the community, by the community. So along with the people I named and 7 community members not attached to any nonprofit organization or city organization, they decided to meet me right in Phil's Corner, roll up our sleeves, and hit the ground running. As Gary Gaffin can attest to, that old school grassroots outreach, and that's what we've been doing for the last 3 weeks. I do have a presentation, but everyone on this call can read, so I prefer to email it to you so you can look at the numbers, and it's just raw data. There's nothing exciting other than the amount of people that we were able to reach, and I will just call that number out. So between myself and the people that we just named, we have reached over 7,000 individuals across Boston. I know 7,000 doesn't sound like a large number, but in 2 weeks with people that are not getting paid to do this on their own personal time, I think that's amazing. So we will talk a little bit more about the next steps with this department's outreach. I do know we will be visiting colleges and affinity groups this weekend because everybody's moving in. So we're getting to the Gay Straight Alliances. We also will be going into Boston Public Schools as well and talking to some of their Gay Straight Alliances, just trying to be creative in with the outreach because we do know, and I'm speaking from personal experience, and we'll talk about this when the panel gets underway, the average Black and brown person will not show up to an event like this. So we have to be creative, think outside the box, and I'm looking forward to doing that work. So thank you, Sasha, for all the work that you are doing, and thank you for giving us your free time today and emceeing this thing. Thank you.
Of course. And that's a great way to leave it off because I think I'm gonna go right back and ask you a follow-up question about that, Quincy, in a second. So for everyone in the audience, this is like a little check-in point. So just a reminder that if you have any concerns, any accessibility issues, feel free to reach out to the organizers. You could do that privately in the chat. You could also feel free to interrupt the meeting at any point. And everyone, please, as it's already happening, but feel free to continue to use the chat function to communicate. The rest of today, the next 40 minutes will be Q&A, and towards the end, there will be an opportunity to read some of like the audience questions out loud, and I'll ask the panelists those questions directly. So I want to dig a little bit deeper into these grassroots efforts that have been happening, and I'm going to ask you, Quincy, and also Dr. Bisola, because you mentioned dating apps earlier. What is being done to specifically reach the Black community? And I'm going to ask kind of 2 questions embedded in that. One is there are intersectional identities in the Black community, including like being transgender, being non-binary, being houseless, being an undocumented immigrant if you are Black Caribbean or Black African. So how are you making sure that those very marginalized parts of our Black communities are being reached in the grassroots efforts?
Absolutely. Thank you for that question. For this department, what we decided to do was be intentional. Well, everything I do is intentional. So what we did 2 weeks ago, we went to Jocks Cabaret. They had their first all transgender performance. It was 5. I want to say 4 out of the 5 were Black and brown. So we went directly to the constituent group. We rolled up our sleeves, went to Jocks and had a good time. And at the same time, we were able to outreach to that Black and brown transgender group that is always the afterthought or left behind. We started with them 3 weekends ago. So that's how this department is being very intentional about making sure that Black and brown, especially transgender women, are getting the access and the information.
So if I could just add, I really appreciate Quincy's boots on the ground approach. I think that's really what's needed. It's absolutely essential. But I have to say that I don't think enough is being done, period. You know, it's not just on one person or one office or on the Health Commission. I just think in general, the information isn't out there as widely as it should be. And I think, Sasha, your point is well taken in that we have an incredibly diverse community out there and no one's using the same way of getting information. Just like Quincy mentioned, this was first brought to him as being the same as HIV, you know, so that was misinformation that was put out there because it was put out there. I mean, because that's what people had heard and that's what they had, you know, sort of seen on social media. So one of the things that I think we're, you know, sort of focused in on as a Department of Public Health is the fact that, you know, people are using social media. So we have to be out there sort of addressing misinformation and disinformation, which I think we're doing and we're actively engaged in. I know the state is doing similar efforts, which I think is important. But then we also have to realize that not everybody, you know, uses social media. So we have to find other ways to get information out there. All of this to say that we need to be doing more, but I do want to emphasize a couple of points. One is that sometimes I think, particularly within the Black community, I'll say this from my own experience, is that there's a tension here because it's like we want to reach those communities who are currently being disproportionately impacted, right? And that's gay and bisexual and other men who have sex with men. But at the same time, we realize that information channels, they may be within those individuals and within those communities, but it may be that they're getting their information from other places. So then how do we get the information to both the general population and we get it to those people who, you know, need it urgently, need it most, without at the same time stigmatizing folks, you know, and without making people feel that they're being highlighted or targeted for specific information or, you know, as causing this problem. So I think balancing that has been a challenge, and any thoughts that others on the panel have about how best to approach that, I think that's worth discussion. If not, you know, even here, but even afterwards, how can we better message? How can we better reach, you know, the dynamic and diverse population that is the Black population here in Boston?
Yeah, that is. Oh, go ahead. Go ahead.
No, I just wanted to add, because she hit a point about the trust, and that's a huge piece of why I'm being so public about my journey and my fear of monkeypox. So shout out to Codman Square Health Center and Todd. I'm actually documenting my journey with monkeypox. I got my first vaccination 2 weeks ago, so I'm recording it. I'm sharing it with my many friends on social media and my family and friends, because I have those fears. I don't trust certain things. So I'm documenting it because I want, going back to what Dr. O said, I want Black and brown people to trust this process because I have my own fears and questions about vaccinations, particularly this one.
Yeah, and I appreciate you sharing that, Quincy. It's very important. I also appreciate, I see the Pan Pride flag out there in your background and many other Pride flags. And I know that's something I picked up on as I'm listening to everyone. I know, Kevin, you explicitly mentioned the trans community in your presentation, and really anyone of any sexual orientation who's having skin-to-skin contact with someone with monkeypox. I think that's an important point as well for our Black community, given how diverse also the queer Black community is in Boston, including binary individuals and people like myself who are pansexual, part of the different identities within the alphabet family, as some like to refer to it. So I do want to talk a little bit more about that mistrust, because it goes into another, you know, area of intersection, which is like the experiences Black disabled people have with government, Black undocumented people have with government, or just like the Black community here in general. What are the prospective government agencies here doing to kind of go a little bit deeper into that? And I heard you, Quincy, and what you were sharing about how you're tackling it at an individual level, but are funds being poured into this? What are the different entities doing to address that specifically?
So if I could jump in just to say, and I know I've already spoken, so I want to leave the panel open for other people to comment. I think a strategy that we've learned to use, because I don't think it was something that we necessarily were using as widely pre-COVID, is having trusted messengers, having people who look like, identify with the population who you are trying to engage, I think is critical. Certainly hearing from folks like Quincy, like others who've put things on social media, showing themselves, getting vaccinated, I think is key. I think people like to see other people who look like themselves providing the services, so actually funding, community health centers where you see other people of color providing and getting the services, I think is really incredibly important. But I would also say that being transparent with what we know and what we don't know, because I think oftentimes we try to give a succinct message and we don't say, well, hey, there's still a lot of questions. We don't know. We think this is the best thing for right now. I think people want to know the truth, so I think being transparent, these are all things, again, that we learned during COVID. So it's like, use the lessons that we learned to apply to other cases.
Kevin and Dr. Esteban, would you like to add to that at all?
I'll defer to you, Dr. Garcia, but if you'd like me to jump in, I'm happy to.
Go right ahead, Kevin. I mean, I was just going to echo what Basola said about the trusted messenger. I mean, I think we learned so much about that. Who do people trust? That's where I think we really do need to strive for that. And I agree. Patients, in all walks of life, want to see their healthcare providers who look like them and have some lived experience. I think is really important, and that's certainly something we need to continue to support.
Thank you so much, Dr. Garcia. And before you jump in, Kevin, I just want to emphasize, as someone who's in the Boston queer community, but also very kind of knowledgeable and aware of justice, lawyering, advocacy, et cetera, there aren't a lot of us here. So there aren't a lot of professionals in government who are Black and queer. There also are not a lot of providers who are Black and queer. So I appreciate what Quincy and Dr. Basola are saying. I'm also eager to hear how those resources and time is being allocated by the different entities here at the table. Thank you so much.
Yeah, it's a terrific question, Sasha. I really appreciate it. I mean, we are building on a tradition, though. We're not new to the public health world, particularly for disease entities that disproportionately impact BIPOC individuals. Our long history of fighting HIV and AIDS, of fighting sexually transmitted infections, and our more recent history in working around COVID, because we saw disproportionate access to information, access to vaccination, access to trustworthy leaders. And so building upon that experience, and in particular, we turn to our own Office of HIV/AIDS and its funded providers, both in choosing those 14 providers because of their proven access to the BIPOC community and to men who have sex with men in general. And now we're reaching out to the larger community of funded providers who have been working in these communities, particularly in the Boston area. I see my friend Gary Daffin on the line. I'll let folks identify themselves, but as you call for folks who are members of the BIPOC queer community, I'm counting on our providers and our larger community relationships to stand up and join us in this work. There are not special resources yet dedicated to monkeypox, even though the National Declaration of Emergency allows for the federal government to allocate special resources beyond the treatments and the vaccines themselves. We're working off our own dollars, all right? And that's no excuse. We actually have resources to draw off of because we have, particularly at the state level, some robust resources in our state line item that allows us to redirect some of the dollars into the work of addressing monkeypox. And that's exactly what we're spending off of right now in engaging not only those 14 providers, but all of our HIV/AIDS providers who have been doing this work so expertly for years, to be places where people can get accurate information and be directed to both vaccination and treatment resources.
Wow, thank you so much, Kevin. And I'm looking forward to seeing that use of those broad resources, but also what sounds like a lot of discretion to kind of combat this crisis as urgently as possible. And related to that, and I want to open this up to all of the panelists because, and I want to be clear as moderator, I do think it's important to make sure we're not stigmatizing the queer community, the gay community, the community that is experiencing this disproportionate number of monkeypox cases by coincidence, is my understanding. So what are your different entities doing to make sure there is not being a stigmatizing happening and kind of entrenched, and how, especially the most marginalized members in communities who might only have a few, if only one instance to kind of learn about this, what are we doing to combat that in a way that addresses what happened in the government during the AIDS and HIV epidemic? And by that, I mean the stigmatization of AIDS and HIV epidemic. Yeah. Go ahead, Kevin.
You know, this is my personal history, right? I'm old enough to remember when HIV was first, before we even called it HIV, and it had all kinds of nomenclature. AIDS had all kinds of nomenclature that particularly named gay men as quote unquote victims. Even that language was problematic, and as the only folks getting this infection. We have to be really careful about our language, our images, our approaches, right? And really scrutinize ourselves and mark the places where stigma is possible, even through misunderstanding. I think it's important. This is a balancing act between making sure no one gets blamed for what is ultimately a viral infection transmitted through known mechanisms. And you speak in those kind of clear and depersonalized terms about the infection itself, and then talking about in very personal terms about who is experiencing this disease, the pain that they may be going through, the need for compassion, the need for support if you're acquiring this particular disease, which can be very painful and can be in and of itself stigmatizing, and balancing that against the need to inform folks at risk. Because the other side of stigma is ignoring people, is ignoring their needs, their need for information, their need for resources and services. So being self-critical throughout the entire process of constructing our messaging, asking members of the community to examine our language, to examine our approaches, to examine our images, and saying, am I missing something here? Because I can't, as a white man, possibly understand what it means to look at some of this language and some of these images from the point of view of someone who doesn't share my lived experience, and listen carefully and honor that feedback.
So I would also add, because I appreciate everything that Kevin has mentioned, and I know that he's worked in terms of HIV, you know, looking at destigmatizing approaches and really throughout his career. I would say that particularly with monkeypox, emphasizing that this is not a gay disease. I think that was our mistake with HIV, you know, is that it was the framing, the understandings, everything that was happening at the very beginning of the epidemic into, you know, decades into it, just maybe not realizing that there are other people who are, you know, suffering from it. So it's kind of looking at this as though this is a gay issue. The way that we're hoping to look at monkeypox is that though we have people who are disproportionately impacted and we are trying to provide outreach awareness, we are trying to emphasize and I think, you know, educate and make people aware that this is not just something that can, you know, happen because one is gay. That I just think that that's a way that we've been trying to move it forward as just in a using a destigmatizing approach. And as Kevin mentioned, being very careful of our language. Our medical director for our infectious disease bureau, Dr. Sari Sanchez, has put some videos on social media that have been, you know, widely disseminated that talk about some of this, as well as talking about, you know, other aspects, the clinical aspects of monkeypox. But it's really been a central part of our messaging, and I think that's really important. I also want to mention that there are other aspects of stigma that's going on here. I mean, when you talk about even calling an infection monkeypox, you know, and can we change the name? And certainly there's a global movement to try to do that. and the strains that are, you know, widely talked about are very much so stigmatizing in themselves also. There's the Congo Basin strain and the West African strain, like this is an African thing, you know, and we clearly see it's not an African thing. What this is an ignorance. By ignorance, I mean ignoring the fact that there are viruses that are endemic to other parts of the world that we're doing nothing about, and look what happens when we ignore, you know, people who are suffering in other parts of the world. So there's been a movement to change the names of the clades or the strains. I think these things are important. It really is about how we describe things, how we talk about illness, things that people are suffering from, things that people are really, you know, experiencing a lot of pain about, whether, you know, physical pain or emotional suffering, you know, when you are diagnosed with something that's unfamiliar to you, and, you know, people are sort of, you know, acting like it's something so odd. So I really think that what we need to do, both, you know, within the local government, as well as, you know, amongst our community partners, is be very cognizant about how we talk about this infection. And I see us doing that, and I see us asking these questions, but I just want to continue, you know, that process for us to continue to think about how we're describing monkeypox, how we're talking about it, and how we're engaging people who are, you know, at this point in time, most at risk in these dialogues.
Thank you.
And I will just add, wonderful, Kevin and Dr. O, I will just add, just holding your colleagues responsible and accountable as well. I sit in a suite with Black male advancement, women's advancement, and immigrant advancement. And I make sure that all those executive directors know that monkeypox can impact anyone. So just as Dr. O said, just repetition and making sure that your colleagues know the information and getting the right information out. So.
All right. Okay. So thank you, everyone. And I'm just going to reiterate for the audience, what I'm hearing very thoroughly and clearly is that this, in fact, is a coincidence that it has predominantly or disproportionately impacted specific Black members of the queer community. It is not a gay disease. It is not a bisexual disease. It is not a Black queer disease. And so it's important to clarify that, but it is also important to address that there is a disproportionate impact and what that means, what that phrase means. So I imagine that Kevin and Dr. Bisolu, y'all might have some insight into this, but I do want to ask about that number breakdown by both race and ethnicity. And I want to just put out there that I do think it's important to not mix those two. As someone who is Black Caribbean, it is not the same to kind of just generally reference the Latin community, for example, without breaking down the racial profile of that demographic. So I'd love to get into the numbers as well.
Sure. I will say that we've been examining not only the case data, but the vaccination data very closely. And we've been spending the last several weeks particularly trying to improve the quality of that data. As you may know, race and ethnicity are not always well reported, not always well captured in like electronic health records or other reporting systems. And so we are utilizing our own epidemiologic capability, because we can look across diseases within our system to try to complement and supplement any data that are not as well reported. And we've even identified that there's some of the reporting systems themselves from some of the electronic health records where the data are present are not getting to us in the ways that we would like. So we're doing a deep clean on the data so that we can be as precise as we can be about race and ethnicity, particularly Latino ethnicity with regard to the data. I don't think it'll be any surprise to you, even looking at the data that we do have, given those challenges, that we anticipate a lower uptake of vaccination from Black and Latino individuals relative to their rates of getting infected. And it's our commitment to you to be sharing those data completely transparently at the point that they are of sufficient quality to really tell the tale. And that will be very soon.
Okay, that's great. And where will that be accessible? Will that be
Oh,
available?
publicly posted. We'll make that publicly posted. You know, we've been issuing a weekly press release on monkeypox, updating the community on a weekly basis on cases and any other major policy changes associated with our monkeypox response, and that would be the format through which we would be being able to describe the data with greater granularity. In the early days of monkeypox, the numbers were so small, we actually had to be very careful about sharing data. It's so as not to label or stigmatize individuals in particular communities, but we're now getting to sufficient numbers and sufficient data quality that we'll be able to provide those data to you at that level of granularity.
Okay. And for folks who don't have access to internet or a computer, or like don't feel comfortable kind of reading this material in English, will that be made accessible to them in some other way?
I will take that as a specific request back to our communications folks who are on the line right now.
Okay, great. And I also meant to add to that question for folks with disabilities that would need like a specific way to access that information.
That's right. I will say all of the mass.gov websites go through full ADA review so that they are accessible through the various mechanisms that people utilize to access the internet.
Okay, great. And just to kind of reiterate what's already been mentioned earlier by many folks on the panel, some folks don't go to events like this, especially it's kind of well known, I think Quincy, you mentioned this, that members in the Black community don't always attend these kind of town halls, and just generally like the internet isn't the only source people rely on. Like maybe there are radio stations or some other creative mechanisms, including some grassroots mechanisms that might be effective. So just kind of repeating what some other panelists have said, I think that was very, very helpful. So we only have a few more minutes left before I open it up to the audience, and I see some hands up. I encourage y'all to write questions in the chat because people have been writing questions, and there'll be about 10 minutes to pick from those questions and answer those. Yes, great. Thank you, Tegan, for adding that in the chat. So going back to what the state is doing, do any of the panelists know whether there's been a state of emergency declared? And if not, or if so, why?
State of emergency at the state level, are you asking particularly?
Yes.
Right. No, there has not been a state of emergency about monkeypox declared. In the federal government has declared a public health emergency, and most of the policy initiatives that we thought were necessary, such as leveraging resources, perhaps obtaining an emergency use authorization for the treatments and the vaccinations, and those kind of policy initiatives are done at the federal level. And we can't identify specific policy things that can be only done if there were a state level state of emergency. So that, I would say, that's our primary response, is that there has not, we don't see an additional policy advantage to a state level, Massachusetts level state of emergency. But we're all ears about what other benefits that might provide.
Okay, thank you, Kevin. And Dr. Esteban, turning to you, two questions that have been lingering for me is one around the side effects of the different vaccines that were included in Kevin's presentation, and feel free to mention any that weren't, including treatments, whether there are any known side effects, and particularly whether there are any specific concerns to children, young adult, or women, including like folks who are assigned female at birth, trans men, non-binary folks, like whether any of those populations are a specific concern to them.
Sure. So, just touching quickly on children. And so, children are at risk for monkeypox. I mean, we've made it clear, I think, in this conversation that this is not a gay disease or something that we should take in that way. Children are at risk. It's a very minimal risk, certainly. And at the national level, it's children represent, at least at the beginning of August, less than 0.1%. 0.1% of all of the cases. So there are some pediatric cases. I think at the beginning of August, there were a couple across the United States. And these cases, if acquired at home, typically are from what we talked about before, from kind of the sharing of, sleeping in the same bed, co-sleeping, those kinds of things. So just something to be aware of in pediatrics. But we also have treatments available for pediatrics, what Kevin referenced, and vaccines available for pediatrics as well. And we want to make sure that the vaccine Jynneos is given differently in pediatrics. Under 18 is still given the way that it was given before the dose sparing or volume sparing method that came up that we're excited about. And the general side effects of the vaccine have been those that we see with many vaccines, and it's fever, sore arm, some malaise. I mean, really general things that we've seen with COVID and lots of other vaccines. And certainly in the pediatric world, we're used to that. When we vaccinate kids a lot in pediatrics, and so we're getting vaccines at 2 months, at 4 months, at 6 months. So really tiny babies get vaccinated, and we see many of those same issues. We are hearing that the intradermal vaccine, the complaints are that it certainly can itch and be, can itch and can be painful. But those, again, it's not something that folks can't deal with, and we know that that's happening, but it's certainly worth getting the vaccine out there, I would say. So I'm not familiar with significant side effects that make taking the TPOXX or the treatment, other than too hard to tolerate. I'm not hearing that that's the case at all. I think it's very well tolerated. I know folks who've shared with me on a personal level that they've taken it and that it really did help their symptoms significantly. In my circles, we know folks who unfortunately were early in getting monkeypox and at this point are interested in making sure they tell their story as well about how treatment has been so helpful and effective for those folks.
Can I just chime in for a quick second around the issue of being able to communicate with young people and the importance of doing that? My name is Takia Brown. I am the Division Director for Education and Community Engagement at the Commission, and I'm formerly of our CAF Bureau for Child, Adolescent, and Family Health. So we are lucky to have 5 youth serving programs that work with young people across Boston throughout the high schools. And as a part of that, we actually work in the high schools teaching sex ed and other health education programs. We have a youth ambassador program that we've been working with pretty closely around COVID, and we have engaged them around making TikToks and other content that's going to be specifically targeted at young people, answering the type of questions that they have. I've already started to meet with our program director to kind of think that through and hope to be hosting like a live stream with our young people. And some of our other youth serving programs have already began to post our monkeypox infographics and things like that across their social media pages, because we know this is important, and we know that our young people also tend to be caregivers in multi-generational households for their family members and things. And sometimes they are the people that are the ones that's actually getting that information out to the older generation. It's coming filtered through them. And so we take that very seriously and have been kind of working with our young people. And I'm sure we'll have some cool stuff to kind of promote back if we ever have a chance to be in this space again. But I just wanted to highlight that.
Thank you so much for highlighting that. And before we open it up to the rest of the audience, I do want to just loop back to Dr. Bisola and ask specifically about therapies available and treatment as well. We've talked a little bit about this, but I just want to make sure that we continue talking about this, since I believe it's on a lot of people's mind.
No, I appreciate that, Sasha. And, Dr. Garcia, explained, and I think in Kevin's presentation, he also mentioned Tecovirimat or TPOXX, and the fact that it's an antiviral and that it is available, but you really have to, in some cases, ask for it. It's, basically for people who are, either experiencing severe disease or those who are at risk for severe disease, particularly people who are immunocompromised. So it's well tolerated, as Dr. Garcia mentioned. Side effects are generally minimal. The data are limited in regards to efficacy, but every case that I've heard of, it really does shorten the duration of illness with fewer lesions. So I think it's important. It's also free, so you need to talk to your healthcare provider about it. I would also say, though, that one of the things I think is a bit underestimated that I have heard of from a number of patients is just the pain that a lot of people are experiencing with monkeypox. You know, either it's anal rectal pain, genital lesion pain, just lesion pain. And you know, I have to say this as a health equity, researcher and somebody who's done a lot of work in this area, that, pain is often underestimated when it's presented from somebody who's Black or brown. I mean, it's known, well documented. We need to just put it out there. So I think in some cases we do need to advocate for ourselves, understanding that, in terms of pain, relief can be just as easy for some people as taking sitz baths. So basically sitting in a warm bath. You may need some topical treatments, either lidocaine or benzocaine gel. Stool softeners may help in some cases. And I'm just trying to make this real for people, that it can be very difficult for some people to manage. And certainly over-the-counter pain medications may work or may not work for other people. You may need opioids, or you may need other, sort of stronger prescription pain medications. And I think there is something to be said, again, about advocating for oneself. I would also say that we're seeing a lot of oral lesions. It's important that our healthcare providers are educated and aware that people can rinse their mouth out with, alcohol-free oral antiseptics. We have like Magic Miracle mouthwash. And I think these things are something that maybe not every healthcare provider knows about. So this is something we need to educate about also. And also realizing that for some people, some of these lesions are, really bad in some cases. They are more severe, particularly people who are immunocompromised, that you may need dermatology. You may need somebody who's seen this before. You may need to get somebody involved who really has, understands what they're doing and can manage the side effects and the symptoms. So I think that's a really important question, something we all need to be aware of, and to understand that there are a lot of people who are suffering, pretty significant pain from monkeypox.
Thank you, Dr. Visola. So before I open it up, and just a heads up, I will be asking Gary Daffin if you could ask your question directly. And I also both want to acknowledge that Senator Wilkerson is here, and then also invite Senator Wilkerson to ask their question directly. But before we do that and open it up to the audience, I want to go over a few access points for where you can get more information after this town hall. So one is you can go to Google, and if you type in Boston Public Health and monkeypox, the first link that will likely show up is Boston's website for monkeypox, which includes a lot of fact sheets in Spanish, Arabic, Haitian Creole, Cape Verdean Creole, Somali, Chinese, Portuguese, Vietnamese, and French. It also includes the email, info@bphc.org, if you want to reach out to the Boston entities, including some of the ones that are represented here on the panel. I also want to put the LesBiGay Foundation email out there in case that's a more comfortable way for you to kind of vocalize some of the concerns you may have. And the email is info@LesBiGay, LesBiGay, urbanfoundation.org. All right, so let's open it up. Gary, feel free to start us off. And if we have time, we can ideally get to at least 5 questions.
Hi, can you guys hear me? Hi. So I don't have a question. I just have a comment, which is I want to make sure that we are clear about what we're trying to do in phase 1 of this, because I understand the issues around stigma, but I'm actually quite concerned about the way that we talk about this, and almost not saying that this is a disease right now that is it's not disproportionately impacting men who have sex with men. It is affecting men who have sex with men. It's primarily, predominantly, almost all the cases. And so I want us to be clear about the fact that we need to get information out to this particular population, and Black and brown men are being disproportionately impacted among other gay men. But we're not seeing women. There are a few children, but we're not seeing like a broader range of people. We need to figure out how to talk to Black and brown, gay and bisexual men, and transgender people who have sex with men. It can be trans women or trans men. And in ways that do not promote stigma, but also do not make it seem that we are somehow ashamed to talk about the fact that gay men are having sex. And we keep saying that this is not a sexually transmitted disease. I think there's some conversation about whether we should be calling it a sexually transmitted infection or not, because the way that gay men are getting this is primarily by having sex. One other point, the other thing that is very troubling is that in some places, the statistics around people living with HIV, men living with HIV who are impacted, are shocking. I mean, it's either like 40, 60%, and I don't understand what that is. I know I was just talking to Dawn, Kevin, we're both sort of trying to figure out why is that? So I think we need to be clear about who we are focused on, and not necessarily try to create. We need to have general information, but we need to figure out ways to reach the people that we need to reach. And I also don't, I don't know whether those of us who were around for HIV experience stigma in a certain way. I don't know if younger people are experiencing that. We just need to be more direct about like what's happening here. And if you're a man having sex with men, you need to get vaccinated. And then we also see that in places where organizations that are run by Black gay men, in DC, in Dallas, in Atlanta, who are offering vaccination, people are coming to get vaccinated. So I don't want us to, I know that there are issues that people have about vaccination in the community, certainly. I mean, I think Quincy talked about that well, but what we are seeing anecdotally is that people, when they're offered this and have access to it, they are taking advantage of it. So maybe COVID taught us that, if we have access to vaccines, we should take them up. So I just want us to be really clear about not ourselves being afraid to talk about the fact that we're trying to reach gay, Black, and brown men, and white men too, but we're particularly focused on, at least at where we see the disproportionate impact among those gay men. And I don't want us to talk around that or miss that, because there's no shame in people having sex. And the criteria that people had more sex with more than 2 people in the past 2 weeks, that's a lot of gay men. So we just need to be clear that we should be talking to the people who are at this point almost exclusively affected. So that's why the whole sort of disproportionate term I worry about.
Heard, Gary. Thank you so much for sharing all of that so thoroughly. So I'm going to turn it over to Senator Wilkerson, and then maybe we'll have time for 1 more or 2 more questions.
Good afternoon, everybody. Sasha, can you hear me? Good. So I can't even tell you how prophetic it is that I'm following Gary Daffin, because it was with Gary Daffin and some of the other folks in our community that we got on a plane in 2000 and flew to DC to meet with the late Senator Kennedy because of our concern about how HIV/AIDS was being handled in the Black and Latino community. And as a result of that trip, Boston got the 2nd highest Ryan White fund in the country when that money was distributed. And I say that to say this, my concern, Sasha, you said it all, and I wanted to just raise this question. We've learned so much about how to connect with people of color, how to connect with immigrants who are dealing with documentation issues during our COVID experience. And we met that experience by adjusting our actions so that we didn't have people feeling uncomfortable. We were able to draw thousands of immigrants to the Reggie Lewis because of how we handled it. We didn't ask people to bring paperwork. We asked people to write their name. And as long as we had the name spelled correctly, right? So wasn't questions about paper and all the things that tends to discourage. Right now, BBC's Black Boston COVID-19 Coalition is involved in this process because we're still doing COVID, and people have been showing up at our COVID vans on a weekly basis and asking questions about monkeypox. And I say that to say, Gary, I hear you, but here's my question and my call to our community. I think the fundamental mistake that we made at the beginning of HIV/AIDS is that we dealt with this as an issue that only impacted one sector of our community. And we all know what happened as a result of that. I mean, we need to educate everyone. Our community is asking questions, which often that doesn't happen. And we do have, as Gary said, a part of our community that's being impacted in a major way. We need to address it. But that to me is about having more than Codman Square be the place you can go. I'm not sure given what we learned in COVID, that having a van that's driving around in our community that people see and know is only going to be doing monkeypox is the right way to go, but I'm open to hear what people are thinking about it. I think that we have to treat this going in as all of our issue so that no piece of the family gets left out to fend for it on their own, because eventually we're all going to be dealing with it. And I, you know, that's a different issue around what, you know, how we deal with the state. But right now in our community, let's use those lessons that we learned around COVID. We know that our people don't get their information from press releases. So to the extent that that's the way that the state is now providing it, we have to have a plan B, because that's not how they get it. They get it from us. They get it from trusted sources. They get it from places that they go and patronize that are familiar to them. They receive it from people that look like them and that that are going to be speaking that same language. And so I would just caution us not to go down that same road and make the mistakes that we made, because I'm feeling right now like that's what we're doing.
Well,
I know that's a lot. I see you looking at you, but yeah.
No, Senator Wilkerson, I really appreciate that. That is quite the note and a way to kind of hit home a lot of what we're trying to say here. And I'll just share, as someone who's pansexual, bisexual, a hug, cuddling. I saw in the presentations, like my community goes beyond the lesbian, gay, bisexual, pansexual, trans community, even though a good chunk of my loved ones are part of the LGBTQ AI+ community. And so thinking about that is important. I also heard what you said, Gary, about making sure we are saying it clearly. This is impacting Black queer individuals, Black gay individuals, anyone in the queer community who is Black, who is like having these not just sexual interactions, but just physical interactions. So I think with that, we are out of time. I was told by some really great helpers and supporters that the questions asked in the chat were answered. Did I miss any, or is there anyone in the audience that wasn't able or didn't find it accessible to ask a question in the chat? Okay, well, with that, I take that as a no, but this was such a pleasure, and it was it was so nice to meet everyone in the panel and also others in the audience who spoke up. I appreciate that. And folks who asked their questions and contributed to the chat as well. So I'm gonna hand it off to Curtis. And thank you everyone for coming today. And also for those of you who will be watching later on, thank you so much.
Thank you, Sasha. You did such a great job, Sasha. You did an excellent job. I just want to first thank the panelists for holding it down and giving factual information. As we heard today, that some information that our community does receive are not always factual. So you guys being the experts in your own spaces and bringing information live and direct. We did stream this on Facebook Live. So those who are a part of this conversation did receive the information as well. And so I just want to say thank you to Boston Public Health Commission, LGBTQ+ Justice Office, Department of Public Health. Also, Sasha, thank you to you as well. Also, BBCC for partnering us in this effort to bring this information to the forefront of our community. This has been a great conversation, and I look forward to more of these conversations to talk about issues that really impact our Black and Brown and queer individuals of color.